This section of the Critical Care Survival Guide will focus on sedation in the ICU. When it comes to sedation in the ICU, you need to ask yourself several questions. Does this patient need analgesia? Do they need an anxiolytic? And between these two, do they need to be IV continuous or IV intermittent dosing? Let's talk about analgesia first. As you can see, there are lots of choices for analgesia, and we'll talk about each of them, but I'm going to give you a hint here. Fentanyl is the major workhorse in the ICU because it's short-acting and relatively blood pressure neutral. It can be given as an IV push or as a continuous infusion, and it's really the go-to analgesic in the ICU. So if you're stuck, guess fentanyl, you'll probably be right. When we use morphine, this is typically used for air-hungry patients, can cause some hypotension. We really don't use a lot of it outside of terminal weaning in the ICU. Finally, Dilaudid is used most frequently for patients who are very opioid experienced, and so they may require very high doses of fentanyl to be controlled, but an equivalent dose of Dilaudid will get them much better pain control. Again, all three of these medications can be given as IV push or as continuous infusions. Let's move on to anxiolytics. It gets a little more tricky here. As you can see, there are lots of choices for anxiolytics in the ICU, but we'll start with my favorite, which is propofol. Propofol is a great medication in the ICU because it works for a large number of patients and is very quick acting. But there are a few problems you have to be aware of with propofol. It can cause hypotension and bradycardia, which are the main side effects that limit its use in the ICU. Thus, it's not a good pressor for example, patients with septic shock. Propofol, interestingly, in the ICU is only given as a continuous infusion. We don't do IV push propofol. IV push propofol is reserved for intubations and procedural sedation and so forth, and has to be given by an anesthesiologist. Our next medication that we use in the ICU is the benzodiazepines. So this can be lorazepam or midazolam, and these medications are great for patients with alcohol withdrawal or who have blood pressure problems and hypotensive and can't tolerate other medications, as you'll see. The benzos can be used as IV push or as continuous infusions, but when you use the continuous infusions, you really have to worry about some of the side effects you can see with the benzos. Namely, there's a significant increase in the rate of delirium with benzodiazepines, and they tend to accumulate as they're used over longer periods of time. Midazolam, this effect is relatively benign in the first 48 to 72 hours, but after 72 hours, midazolam accumulates just like lorazepam, and this effect is most severe in patients who are elderly or who have chronic liver or kidney disease. Again, if at all possible, I prefer to use IV push, PRN doses of the benzodiazepines because of these potential side effects, but some patients will need a drip. Our next sedative or anxiolytic is Haldol. So Haldol actually is a really great drug for patients who are delirious and is relatively neutral on the respiratory rate and the blood pressure. For this reason, you can give it to a lot of patients in the ICU as you're trying to wean them off of their sedation and off of the ventilator. A few things you need to be aware of. It can increase your QT interval and cause arrhythmias, and you also have to watch out for extrapyramidal side effects, such as tardive dyskinesia. Typically that happens with more prolonged use, but you can see it acutely. The last anxiolytic that we'll talk about is relatively new and goes by the trade name of Precedex or dexmedetomidine. No, I don't own stock in the company, but most people know it better by its trade name. So dexmedetomidine is great for short-term sedation and as relatively short-acting. It's also very good for patients who are delirious and can be used in addition to or in place of Haldol. The side effects are relatively similar to what you see with propofol as far as hypotension and bradycardia. This medication is only available as a continuous infusion and cannot be given as a PRN dose. So you may be asking yourself, that's too many choices, what's best, what do I use for my patient in the ICU? The answer to this, as most things in the ICU, it depends on the patient. But what I'll tell you is really what you want to target is their RASS score. What this is the Richmond Agitation Sedation score that goes from +4 to -5, with 0 in the middle being a patient who is alert and calm. +1 would be slightly anxious but not agitated, and -2 would be still able to open their eyes to auditory stimuli for a short period of time. So what sedation you use is whatever it takes to get your patient in that RASS score. So that might be, for a septic patient, a fentanyl drip with PRN midazolam. That way you're relatively blood pressure neutral. Or for a general ICU patient, MI, something along those lines, you might consider a propofol drip with PRN fentanyl. Again, the combination options are endless, but really should be tailored to your patient. Again, you want to, whatever it takes to keep your patient in that goal RASS, restless to light sedation, is ideal. I just want to point out briefly that as you're thinking about your sedation, you also want to remember to do a daily sedation vacation where you pause your drips and allow your patient a chance to wake up. This is your best chance to assess their neurologic status and help evaluate if they're ready for extubation. This concludes this segment of the Critical Care Survival Guide on sedation. Thanks for watching. Never mind, I won't do it.
Yeah, we're in business and the battery's low.
Okay. This section of the Critical Care Survival Guide will focus on sedation in the ICU. When it comes to ICU sedation, you need to think about several things. Does this patient need analgesia?
Again.
This section of the Critical Care Survival Guide will focus on sedation in the ICU.